The Huddle podcast is supported by members like you and sponsors like Embecta. Embecta, formerly part of BD, is now one of the largest diabetes management companies in the world. Embecta is singularly focused on improving the lives of people with diabetes so that they may live a life unlimited by diabetes. To learn more about Embecta, visit embecta.com, that's EMBECTA.com, or follow them on social media. Hello, and welcome to ADCES's podcast, The Huddle, Conversations with the Diabetes Care Team. In each episode, we speak with guests from across the diabetes care space to bring you perspectives, issues, and updates that elevate your role, inform your practice, and ignite your passion. I'm Kirsten Yale, the Associate Director for Research at the Association of Diabetes Care and Education Specialists. Today we bring you a special episode that was recorded on location at ADCES22 in Baltimore. Over the next few weeks, we're bringing you captured conversations from the conference. If you haven't attended an ADCES conference yet, these conversations will serve as a window to the experts, technology, trends, and topics you'll find at the event. It's not too late to get access to these, as select sessions are available on demand now through October 24th, 2022 at adces22.org. Today's discussion is a conversation on health disparities between Dr. Eva Vivian and Dr. Daphne Smith Marsh, two pharmacists and certified diabetes care and education specialists. You'll hear their perspective on the environmental and social factors that contribute to health disparities, both in and out of the clinical setting. You'll hear how diabetes care and education specialists and other healthcare professionals can address health disparities in simple, practical ways that meet the needs of the individual while building trust. Enjoy the show.
Hi, my name is Eva Vivian, and we're live at the ADCES 2022 meeting. I am a professor at the University of Wisconsin-Madison School of Pharmacy, and I am actually celebrating my 20th year as a member of this wonderful organization. It's my distinct pleasure to introduce my friend and colleague, Daphne Smith Marsh, who is a faculty member at the University of Illinois College of Pharmacy and a DCES pharmacy specialist at Miles Square Clinic, and is also the Director of Diversity, Equity, Engagement, and Inclusion. Today, we're going to talk about health disparities and their impact on diabetes self-care management. So I'd like to start off by thanking Daphne for joining us and asking you, Daphne, to tell us a little bit about yourself and then actually explain what health disparities are and how they impact diabetes and the difference between health disparities and health equity.
Absolutely. Thank you, Eva. It's wonderful to be here and to see you after so many years of having virtual sessions. So it's a pleasure to be back in Baltimore. I have worked in diabetes care for almost 24 years now. So after I graduated from UIC, I decided to do work in diabetes and internal medicine, endocrinology, and now I work at a FQHC, Miles Square, where we're addressing a lot of the health inequities. So what is health inequity? It's preventable differences in the outcomes of disease, burden, among socially disadvantaged groups. And we know that a lot of social determinants of health will impact the ability for patients to get the same type of optimal healthcare benefits or outcomes. So health equity, what is that? A lot of times we hear equality versus equity. So equality is everyone getting the same type of resources. But health equity is going to address the individual person's needs. So we want to make sure everyone has fair and just opportunities for great health. So I like to use an illustration. We've seen even in our general session about equality, everyone standing on the same bricks, but not everyone can see over the fence. But in health equity, we notice that maybe a person has a different ability or someone in a wheelchair. Instead of the bricks or the crates they're standing on, someone has a ramp to be able to see over the fence. So we're looking at the individual's need. And we know that certain social determinants of health, such as poverty, the environment, we know that a lot of people don't have the same access to healthy food, so health insecurities. We know differences in education impact literacy. Health literacy is really something that will affect the type of care patients will receive.
Thank you, Daphne. That's really important to point out because we're all not starting at the starting gate with the same resources. Could you provide some more examples of some of the health disparities that you've observed when caring for patients in your clinic?
Absolutely. So as a pharmacist, I always think about medication taking behaviors. And as a CDCES, I kind of think about the patient globally. But I know that patients have difficulty with obtaining medications. Either they're uninsured or underinsured. So meaning that they are not able to afford, for instance, the copays for the medications that they need. Also, when we deal with disparities, we think about literacy. So oftentimes they might not understand the terms or might not have materials that are in a language that they can best understand. And though we know that Spanish is the second most common language, it's hard to find certain materials. And I work with patients with all ethnicities. I have a patient who speaks Indonesian. So I'm fortunate to have a phone interpreter to help me provide the education I need. But guess what? There aren't any resources for diabetes education in that language. But we've had issues with technology. So one of the things, particularly with COVID-19, we saw that because patients couldn't come into the clinic, we had to communicate with them virtually, either through video visits or by telephone. But not everyone has reliable internet or a smartphone. So one of the things, actually a research project that we started before COVID-19, so I've been doing virtual health for many years now. It's called the Mobile Health Diabetes Study. So we were looking at patients with type 2 diabetes in Latino and African American or Black populations, the impact of pharmacists and community health workers. So someone from their culture going to their home, and they would communicate with me as a pharmacist and other pharmacists within that project virtually. So we were able to communicate. I could say, let me take a look at what you have in your pantry. We would kind of talk about food labels or medications or different aspects of diabetes care within their home, and they felt comfortable. COVID-19 kind of affected our ability to do that, but that's when we found that there were other health inequities, and technology being the number one we identified.
I know exactly what you mean. I'm always surprised by how few people can use the technology that's sometimes even available to them in their own home.
ADCES22 on-demand access is available from August 22 through October 24. If you already registered for ADCES22 in Baltimore, then on-demand access is included in your registration, free of charge. If you missed the in-person event, this is your chance to access select recorded education sessions and earn up to 20.5 continuing education credits. While you're there, visit the virtual exhibit hall and access leading education, research, and industry posters. Visit ADCES22.org for more details.
Want to kick off a diabetes prevention program in your community? Sign up for an ADCES lifestyle coach training. Build an engaging and empowering lifestyle change program that gets recognition, revenue, and results. Already a coach? Enhance your skills through our Building Your DPP workshop or an advanced coach webinar on retention, habit formation, or other topics. Learn more at diabeteseducator.org/prevention.
Another factor that influences the health of many patients from underserved or under-resourced communities is implicit bias. I can recall on one occasion a patient visiting my clinic for diabetes self-care management, and she was in so much pain that she could not stand up. Of course, I couldn't address her diabetes because her pain was the most important issue. And I inquired about her pain medication. She informed me that her doctor would not write her a new prescription for her pain medication. Well, her doctor happened to be in clinic that day, So I stopped by her doctor's office and mentioned that the patient was in my office and she was in extreme pain. Her doctor responded by stating that she recalled seeing the patient just a week ago and she ordered a urine test, and that urine test returned negative. And the doctor concluded that the patient was probably selling her medications versus taking them. So I went back to my office and I spoke to the patient, and I told the patient that I in fact spoke to her doctor, and I asked the patient, did she recall giving a urine sample that day? She said she did. And I informed her that that urine test returned negative. And I asked her, could she explain why the test was negative? And she responded, of course. I didn't take the medication that day. I was caring for my grandchildren. And when I'm taking care of my grandchildren, I don't take the medication because it makes me very drowsy and I need to be alert when I'm caring for my grandchildren. So upon hearing this, I went back to the doctors and reported this information. And of course, the patient received her medications that day. But that was a perfect example of the doctor assuming that this patient did something illegal because she had an unconscious bias about a person that looked like the patient in question. So could you talk further about implicit bias?
Sure. I think so many times we don't realize we have unconscious bias, or there are hidden bias and certain stereotypes. We might have had an interaction with someone that might have been negative. So we make assumptions about the person before really understanding the situation. And we do know that implicit bias can in fact impact communication, particularly in diabetes care. So the American Diabetes Association, their 2020 sessions that were virtual, they actually had an abstract that identified the impact of provider communication on diabetes care. So A1C in Black patients was 0.64% lower in persons who said that their providers explained results and medications compared to those who did not have full explanations. So oftentimes, if we're interacting with someone, we might have a different approach. So even considering using technology in, let's say, an African-American patient with type 1 diabetes, the provider might be less likely to use certain technologies because they're assuming, or they have implicit bias about the fact maybe they can't understand the technology or they won't have the access to technology. So implicit bias could impact different aspects of diabetes care.
Thank you. It's really apparent that implicit bias is detrimental to the trust of the patient-provider relationship. And it's something that we really, as healthcare providers, need to address and really reflect upon, each and every one of us, because we all hold biases of some sort. So there's apparently a call to action. What is the role of the diabetes care education specialists, as well as other healthcare providers, in narrowing the disparities gap that we currently see?
Sure, absolutely. I just want to state that this meeting, ADCES22, has been outstanding. We have had several sessions that are identifying and addressing implicit bias and health disparities. For example, one of the general sessions, the impact of equity on treating individuals with excess weight, really showed us the impact of our words, how our words will impact patients and how they might not feel comfortable sharing information with us. We also see how weight bias, we have assumptions, oh, this person is not exercising or they're not eating the way that they should just by their appearance. So we don't know what challenges they might have. There was a great evening session last night, Stopping the Syndemic, the strategies for managing glucose and promoting weight loss, where one of the presenters had videos from her mother, who is a person with diabetes, and her mother shared the concerns about the provider not communicating with her. She wanted to discuss certain options, but she wasn't given the opportunity to. And so she wanted to change her provider because she didn't have the trust in that relationship with her provider. Even this morning, this wonderful session with Dr. Gavin, Dr. Hill Gordon, Dr. Sherrington, reducing health disparities in urban and rural diabetes prevention and management. So oftentimes we think about urban areas where there are health disparities, but even in rural areas, there are a lot of persons with diabetes who don't have the same access to care as other persons. So what can we do as certified diabetes care and education specialists? We can look within. Let's take a look and see what our implicit biases might be. Let's look at the assumptions before we interact with a patient. What are some things that we have to consider? Look at our terms that we're using. We need to make sure language is simple and easy to understand, but we need to check our messaging. A lot of times, negative worded phrases affect the patient differently. So I try to use a positive approach. So we need to use evidence-based. So instead of like judgmental statements, let's say the evidence, or we have found that if you're making these changes in your lifestyle, this is how this could help your diabetes. We have to understand the individual. We have to put ourselves in their shoes. We have to see what concerns they have. Let's listen to the patients more. We all have limited time periods in our appointments, but let's take a couple moments to really address their needs. Let's talk to the patient. Let's see what is happening in their environment. So often patients, I'm from Chicago, they might not feel comfortable exercising or walking in their neighborhood because of safety. We have to consider, I always ask, what can you do inside? Where do you feel comfortable? Where can you increase your activity? So we have to consider what works best for them. And again, trust is fundamental, and it dictates how receptive the individual is going to listen to and engage with the treatment plan. So one of the things this organization can do is maybe identify some of our educators who speak other languages. We can expand some of the tools that we have on our website. So, for instance, if there is another language that an educator might be able to be proficient in, why don't you help and volunteer? Let's get some more materials. It's not just English and Spanish. There are other languages, and we need to broaden our access to diabetes care and include everyone.
Thank you. That was very insightful. I feel that COVID-19 really exposed the disparities that we face in our country. And I think it's important that every healthcare provider be viewed as what I would term a trusted messenger. During COVID-19, I was able to talk to many people who were hesitant to be vaccinated. And it was just interesting, all the misinformation that was available to these people about the vaccine. And what was very concerning to me was many people's hesitancy to talk to their healthcare provider about the vaccine because there wasn't that trust. So we as healthcare providers, and especially diabetes care education specialists, should be familiar with the communities that our patients come from so that we know some of the barriers and challenges that they face to leading a healthy lifestyle. Thank you so much for your comments. Is there anything else you'd like to add before we close?
I'm encouraged by being at this conference because I think a lot of things that hadn't been addressed as much, or we didn't have the focus on the health disparities. We had great sessions that identified the need to continue to move forward in health equity.
Absolutely. I agree. This was a wonderful session. And I must say that over the last 20 years, I will still say that this meeting was the best meeting I've attended to date. Thank you very much.
Thank you.
Thank you for listening to this episode of The Huddle. Make sure to download the resources discussed on today's episode. You can find them linked in the show notes at diabeteseducator.org/podcast. And remember, being an ADCES member gets you the access to many resources, education, and networking opportunities. Learn about the many benefits of ADCES membership at diabeteseducator.org/join. As we end this episode of The Huddle, we wish to thank Embecta once again for their support. Embecta, formerly part of BD, is now one of the largest diabetes management companies in the world. Embecta touches the lives of more than 30 million people living with diabetes in over 100 different countries. For more information, go to embecta.com, that's EMBECTA.com, or follow them on social media. The information in this podcast is for informational purposes only. It may not be appropriate or applicable for your individual circumstances. This podcast does not provide medical or professional advice and is not a substitute for consultation with a healthcare professional. Please consult your healthcare professional for any medical questions.